All right, guys, I think we're ready. So here are the goals. To briefly identify and explain key areas of outpatient medicine, and then to highlight which areas are highly testable, ones that you're likely to see on boards specifically. So we're going to go through a number of different topics today. All right, so first we're going to start out with statistics. There's a lot to cover here, and this is an area that you will see many questions on boards on. So let's start with p-values. So this is a way of expressing the likelihood that results are due to chance, and so you want a low chance that the result that you got was due to some minor chance. So a p-value less than 0.05 is considered significant, but it's also important to weigh the clinical significance versus the statistical significance. So let's say you have a study that has 3,000 people and you're looking at lisinopril versus losartan and then looking at the mean blood pressure after treating with like 6 weeks with one of those two agents, and the mean systolic blood pressure for lisinopril is 123 and the mean systolic blood pressure for losartan is 125. If you have that many people, you may be able to find statistical significance, but there's very little clinical significance. And so usually people will look at this, but it's also nice to kind of refer it back to like how you would actually use that in clinical practice. And then some people find that it's not as helpful as confidence intervals. So confidence intervals usually expressed as a 95% confidence interval. And so that's basically saying that the person that's doing the study is 95% confident that the value that they got is included in a specific range of values. And so this confidence interval is impacted by sample size, and so usually larger sample size will yield a more narrow confidence interval. So when looking at these, you can see that this study C probably has a small number of patients, so a smaller sample size, so it's going to have a wider confidence interval. And then this sample D, more narrow confidence interval, so likely to have larger sample size. So you get kind of these more precise values. And then looking at confidence intervals that cross this 0 value, these are considered not to be significant. So this is something that I would encourage you all to do kind of when you get into boards. They'll make you kind of go through, I believe, the tutorial before you can start writing stuff down. So I would scratch down this kind of 2x2 cell. And it's always important, I had trouble remembering, is it tests on this side? Is it disease up the top? Is it positive first, negative first? But just, you're plugging in a test and then you're getting kind of like a result. So I kind of put tests on the left side and then disease up top, and then you're going to use kind of these values to calculate your sensitivity. It's not true addition, and then these are for specificity, and then going across. So looking at these values, you can get positive predictive value and negative predictive value. So these are kind of concepts that we're all familiar with. So highly sensitive tests help to rule out the disease, and then highly specific tests help rule in disease. And so when looking at the predictive values, positive predictive values, you're basically adding up all those kind of positive things. So you have the total positive over the total positive plus false positive, so that gives you the likelihood that someone with a positive test has the disease. So how predictive is that test? And then the negative predictive value is exactly the opposite. So how predictive is a negative test? So how often does that correlate with someone that does not have the disease? Any questions on this? You'll get to use some of this stuff coming down the line. So likelihood ratios, this is actually something that I really like, but it's often hard to discuss in clinical practice because it's both hard, a little difficult to calculate, and you also have to know your pre-test probability to help you out. So here's the calculation right here. You need to know your sensitivity and specificity. We won't really go over calculating that right now, but it's helpful because you can use this likelihood ratio to determine your post-test probability of having a disease. And so this is kind of this nomogram that we use. And so there you have your pre-test probability. So that could be something like, if you're using a risk calculator, like something like, the Wells or Geneva score, that gives you kind of your pre-test probability. And then you have a test, so that could be something like D-dimer or a CT angiogram. That test, has a likelihood or ratio associated with it. So you basically take your pre-test probability, and then once you know your likelihood ratio, you're going to kind of draw a line through that likelihood ratio, and then you end up with kind of your post-test probability. So it takes a little bit more work to kind of get all this information, but can be really helpful in clinical practice. And I definitely think that likelihood ratios give you the most information. All right, so here's our first question. So you have a new drug, and it's being studied to see if it can reduce IPF mortality, and 509 patients are enrolled. 252 in the treatment group and 257 in the control group. You're likely going to have to write some things down to do some arithmetic. And after 5 years, 226 remain in the treatment group and 201 remain in the control group. So what is the absolute risk reduction? All right, so I'm going to ask for a show of hands. So, who thinks A? And this includes the VA because I'm watching over there. No takers. B? No takers. C? All right, got a few people over here, but VA is not sure. And D? All right, got a couple people. All right, so the correct answer is C, and we'll go through this. So you have 509 patients. They're in these two groups, and so I made you do quite a few calculations in order to kind of come at this result. So when looking at mortality, what you want to do is look at the people that pass away in the different groups. So that's 26 out of 252 in the treatment group, and then 56 out of 257 in the control group. And so I tried to make the math pretty easily. I mean, it divides fairly simply, and so you get kind of 0.1 in the treatment group and 0.2, and so the absolute risk reduction is kind of that, you subtract the like event rate with the control rate, and it's the absolute value. So it's 0.1 minus 0.2, which is 0.1. So it's a 10% reduction. Sometimes in the literature, you'll see something called relative risk reduction. And what they're doing is they're taking the absolute risk reduction and then dividing it by this control event rate. And so you're taking this absolute risk reduction, 0.1, and dividing it by 0.2. And so sometimes people will say the relative risk reduction is 50%, and that's misleading. And so what you really want to know is the absolute risk reduction. Any questions on that? That's a pretty common question on boards, is the absolute risk reduction. All right. So knowing the absolute risk reduction of 10%, how many people do you need to treat with the study drug in order to prevent one death at 5 years? All right, so who says A, 100? B, 10? All right, got a few hands. C, 5? And D, 50? All right, good, yeah, exactly, it's 10. So the number needed to treat is the question here, and so that's 1 over the absolute risk reduction, so you're dividing 0.1 into 1, so you get 10. The number needed to harm is like if you're trying to figure out, you have a study, you're looking at the percentage of patients that end up with some type of adverse event. And so it may be due to a medication or a diagnostic or treatment study. And it's essentially measured the same way. So you have that event rate, and then you just kind of will divide 1 over the absolute risk increase, so the risk of developing that adverse event. All right, third question. So you have a 63-year-old man with hypertension, diabetes, and COPD who presents to your clinic as a new patient. He's had all the recommended immunizations as a child and did have chickenpox. He gets a flu shot yearly and had a tetanus booster at 4 years ago. He wants to know what other immunizations are recommended at this time. So the first one, so Pneumovax now and at age 65, and I'll just kind of read through these. Pneumovax now, and this should actually be, and then Pneumovax again with the Prevnar at age 65. Pneumovax and Zoster now with Prevnar at age 65 and Pneumovax at 68. And you'll get a question like this. It's really confusing to kind of read through all these. Pneumovax now, Prevnar at 65, and then Pneumovax again at 68. All right, so who is going to give Pneumovax now and then again at age 65? What about Pneumovax now and then again with the Prevnar at 65? And then what about this really long one? So it's really confusing. It's Pneumovax and then Zoster now, and then you're going to give the Prevnar at 65 and Pneumovax again at 68. So I saw a couple hands here. And then the other one is very similar to that, but without Zoster. And so I had a couple people say C, which is the most confusing one, but actually the right answer. So, we'll go through this whole table. This is the CDC table. And there's a couple things that I'd like to point out with these different things. So, for influenza, we'll just kind of go down the list. The kind of key points to know is that you can use a higher dose in patients that are 65 or older. And then you should definitely avoid the live, attenuated, and immunocompromised people. For Tdap, the interesting thing, and this may get tested, is that pregnant women at 27 to 36 weeks gestation will get this regardless of when they got it before. So if they got it like 2 weeks before they got pregnant, you're going to give it again. That's the recommendation. And then for MMR and varicella, don't give to pregnant or immunocompromised people. And then for this Zoster, don't give to immunocompromised people. For HPV, question.
Zoster starts at 50 now, right?
So I pulled this off the CDC website, so they may have not updated it. Does anyone know the difference between males and females for HPV? So when would you start for both groups?
Ideally before they start.
Yeah, so what's the youngest you can give it, I guess? 11. 11. And then when are you going to go up to for females if they haven't gotten it? 26. And then what about for males? Yeah, so I heard there's a little maybe confusion, so there's two different numbers. So 21 for all males, and then if you have a male that's immunocompromised or is MSM, then you can give up to 26. And then for the kind of two things to know about the Prevnar and the Pneumovax. So if you give the Prevnar, this is the 13 first, when can you give the Pneumovax after that?
3 months.
So I heard 3 months, that's close. So you can give the Pneumovax 8 weeks after Prevnar. If you give the Pneumovax first, when are you allowed to give the Prevnar?
If they got it before 65, then 5 years after the switch.
Yes, exactly. So, but the question that I was asking is if you give the Pneumovax first and then you want to give Prevnar, like how soon after that can you give? Yeah, so you're saying 1 year. Yeah, 1 year. And so then when you get into it and you have special populations, so people that are at higher risk, so people with chronic lung disease, so like the guy in our STEM, the recommendation is to get both, and he would get the Pneumovax, so the 23 before age 65, and then get the Prevnar at 65, and then he would get the Pneumovax again. So you wouldn't give that right at 65 because if you remember in the question, he was 63, and so you would give it at 68 in order to be 5 years after that kind of first dose. Any questions on these? This is, is this going to be something that you're going to have to commit to memory kind of right before the test is usually pretty helpful. And then let's go through some other like special populations. So you have a 27-year-old man with HIV. His CD4 count is 346. It's been stable over the last year. He's on antiretroviral therapy. He presents to clinic for routine follow-up. And the flu vaccine is currently available, and you recommend that he gets it. He has a friend who also has HIV whose doctor told him he cannot get certain immunizations, and so he asked you which ones he's not allowed to have. And so the options are MMR and varicella, MMR, varicella, and Tdap or the booster, MMR, varicella, and zoster, or he can get all recommended immunizations. So, who thinks A? All right, who thinks B, C, and D? Yeah, so I got a couple people for D. That's actually correct. So this one's a little tricky because in patients with HIV, if they have a CD4 count less than 200, then definitely the MMR, the varicella, and zoster are contraindicated. But if it's been greater than 200 for more than 6 months, then you can give the MMR and varicella. And I think that's kind of the big thing that I wanted to kind of hammer home. That may or may not come up on board, so that's kind of like a little interesting thing that you could give it in this kind of big population, but only in some people. Any questions about that? All right, next we're going to go through screening. Some of these are going to be rapid fire, and other ones are going to be kind of more tedious. So, substance abuse, definitely screen for tobacco abuse and alcohol misuse, but currently the United States Preventive Services Task Force does not recommend screening for illicit drug use. However, most practitioners will do this because if they're using, especially like IV drugs, they're at risk for contracting certain infectious diseases, and then you want to kind of screen or look for those. And so most people will ask about these. I think we all do. So the infectious diseases that we're talking about, so chlamydia. So you're going to screen all sexually active women who are 24 and younger. And then if they're older than 24, you're going to screen people, women, with risk factors. And these are the typical kind of like high risk population. So, not using, barrier protection, multiple sexual partners, people in different lines of work. And it's not currently recommended to screen men for chlamydia. And for gonorrhea, you're going to do pregnant women and then sexually active women with risk factors. And then again, not recommended in men. And then when you're if you're either screening or looking for these in men or women, so in women you can check for chlamydia in urine, but for gonorrhea you have to do a endocervical swab. In men, when you're looking for it, like they have symptoms, then you can check for both of these in the urine. And so, most people, when they're checking for one, are going to check for the other. So in females that I'm worried about an STI, then I'll do in-cervical swab for both. If you're just doing a screening, say in that, younger than 24 age range for women, then certainly just doing the voided test for chlamydia is okay. So for HIV, we kind of all know this, so that's going to be, most of our adult population should be screened once, and then at-risk individuals, you should consider screening definitely more frequently than that. And then pregnant women, and then hepatitis C, so those born between 45 and 65, and then anyone with HIV, and then anyone with risk factors. And then syphilis is going to be pregnant women, and then high-risk individuals, and then TB, you're going to screen for anyone that has HIV, you're going to screen for TB, and then anyone that has risk factors. We here are very familiar with the risk factors for TB. Any questions about those? All right, so a 53-year-old woman presents to clinic as a new patient. Her friend was recently diagnosed with colon cancer. She has no complaints and no family history of cancer. What is an appropriate screening regimen for her? All right, so this is who says FIT test, a stool test every 3 years, flex sig every 3 years, CT colonography every 10 years, or colonoscopy every 10 years. So I think everyone got that. VA is slow on the uptake. All right, so you will most likely get a question about screening for colorectal cancer on board. So it's going to be patients that are aged 50 to 75, and then you can obviously elect to start earlier for patients at higher risk. And so those patients could be people with like familial cancer syndromes, or people that just have higher amounts of colorectal cancer in their family, like first degree relatives. That's a completely different conversation. We're just talking about screening in the general population, people with general or normal average risk. So you can do the stool test every year, the flex sig or CT colonography every 5 years. This was kind of interesting, and I don't think that I remembered this. You can do a flex sig with a stool test yearly. So the flex sig would be every 10 years combined with a yearly stool test, or you can do the colonoscopy every 10 years. And so that's just for screening. Once you kind of get in there and you have something, then these recommendations change. All right, lung cancer. So these are going to be in high-risk individuals, and it's going to be annual, and these are patients aged 55 to 80 who have a 30-pack year history, and that anyone that's quit in the last 15 years is still up for grabs. If they quit more than 15 years ago, typically we don't screen those people. Questions about that? AAAs, so these are men, smokers, who have ever smoked, age 65 to 75. There's no recommendation on women who have smoked in the same age range. I guess you could kind of weigh the risks and benefits. I will kind of throw out that physical exam for AAAs has minimal diagnostic utility. Prostate cancer, so the Preventive Task Force says don't screen for prostate cancer, but I think when you take in all the other recommendations from other organizations, most clinicians usually have a conversation with their patients and use shared decision making. So you definitely want to discuss the risks and benefits with them. I think in my practice, what I've usually done is, the people that are high risk, so these would be, African Americans or people that have had early kind of aggressive or invasive prostate cancer in their family and a first-degree relative, then maybe I would feel okay with, kind of starting screening at age 50. Some of the organizations said that you would start screening these higher risk people earlier, so 40 to 45. And then aren't any really good guidelines or recommendations on if you have a normal PSA, what to do with that, and how often do you keep screening. But I think the Urological Society says every 2 to 4 years, and so I think with my patients I've done 4 years, and most of them are okay with that. The big thing that you want to discuss with them when you're talking about risk is, so like if you have an elevated PSA, there's a high likelihood of getting a biopsy, and they're likely to find something on that, whether or not that's going to end up being clinically significant down the road for them. You just kind of have to discuss. The surgery specifically holds a lot of morbidity. And if you talk to them about incontinence and erectile dysfunction, most people are going to say no way. Osteoporosis, and so it's women greater than 65. You consider screening women that are less than 65 if they have an elevated risk, and so that would be a risk that's equivalent to someone that's age 65, which is 9.3, and you can use the FRAX calculator, which you can get online. And then the general recommendation is, say it's normal or osteopenic, you're going to continue screening, kind of every 2 years. And I think most people in practice will screen people who are on chronic steroids, especially like higher doses, every 2 to 3 years. So people, and these could even include people that have really bad COPD that just can never seem to, get off a steroid burst or a taper or something. And so I've done it in that population. Breast cancer, so women age 50 to 74, it's every 2 years. Different organizations have different recommendations. So the Radiological Society and I think ACOG recommends yearly. And so when we're ordering mammograms and we get the report back from the radiologist, they'll put in there recommend repeat screening in a year. But the United States Prison Service Task Force says every 2 years, and then you can consider, starting earlier in people that are higher risk. And so this is coming from the other societies, and so this would be strong family history, or cancer syndromes in the family, or women with high breast density. And then there's unclear utility of people doing self-breast exam at home or coming in and you doing a breast exam in clinic. All right, so you're seeing a 67-year-old woman in clinic for her annual well visit. She wants to know if she still needs a pap smear. She has no history of cancer or abdominal surgery. Her last pap smear was 6 years ago, and her last 3 pap smears have been negative. What is your recommendation? All right, who says A, not needed? Got a couple of people for A. B, check for high-risk HPV serotypes. Cytology, so that would be a PAP. And cytology plus HPV. All right, a couple of people for the last 2. So it could either be C or D. And so this one is tricky because we can go through this, that if women are over the age of 65, you don't screen, but there's a caveat to this. So if they've had 3 negative cytology or 2 negative cytology plus HPV, and the last one has to be within the last 5 years. And so that was kind of like in her last one was 6 years ago. I know. You might get something similar to this, maybe not exactly as nitpicky as this, but kind of the other things to know, you may get a question that asks about screening in someone that's less than the age of 21. Definitely do not screen those people. And then 21 to 29, you're going to do cytology every 3 years. And why do we do that? Why don't we do HPV in this kind of younger group?
They clear the infection.
Yeah, exactly. So they're more likely to kind of clear the HPV infection. And so once you get to the age 30, you can do cytology plus HPV, and then you only have to do it every 5 years.
In this patient, there is no point to doing HPV, right? Because she's had 3 negative packs before. So what are the odds that she acquired a new HPV infection?
Oh yeah, I agree. I would just say, so I wasn't really specific in the question of whether or not she had PAP plus HPV or cytology plus HPV. I think if this was a patient that was getting cytology plus HPV and she hadn't had one in the last 6 years, that I would repeat that same test. If she was only having cytology and the last one was 6 years ago, then I would just do cytology this time. Yeah, good point. All right, so we're going to go through some common complaints now. We got through all kind of what most people think of as the boring part of general internal medicine. So for cough, we're going to go through acute, subacute, and chronic. So the acute time course is less than 3 weeks, and you have this kind of differential diagnosis. The main ones you want to think about are URI and acute bronchitis. But the kind of one that you don't want to miss is bacterial pneumonia. So the tricky thing is, so we're always worried about bacterial pneumonia, but purulent sputum actually can't help you determine whether or not they have a viral or bacterial infection. And so you kind of need to use other signs or symptoms. So if they have fever or other things that you're worried about, they're maybe really tachycardic, or they have lower blood pressure in the hospital or in the clinic, then you can do some more diagnostic testing. That's really to look for bacterial pneumonia. And then if you suspect a viral infection, so like URI or bronchitis, definitely do not give antibiotics. I saw one figure that like 70% of patients in the United States that present with URI or bronchitis get antibiotics. So that is terrible. Subacute cough, so these are 3 to 8 weeks, and this could either be post-infectious cough, which is definitely the most likely diagnosis out of this group, the most common. You could get pertussis or early recognition of someone with a chronic cough. And so, again, if you think that this is just post-infectious, like they had a viral illness and now they don't have any concerning signs or symptoms, then don't do any more diagnostic testing, and you can actually just treat them with either inhaled ipratropium, or if they have wheezing on exam, you can give them a beta-2 agonist. And this is definitely short term, so I think we've seen patients that had maybe had a post-infectious bronchitis that got stuck on an inhaler, and then they switched PCPs. We're now seeing them, and they have this albuterol inhaler that they've had forever, but they have no diagnosis of asthma or COPD or any reason that they have it, but they really like it and they want it again. So, definitely use a short course, and then if they fail, like especially the ipratropium, some people will use inhaled corticosteroids, but this isn't an overarching recommendation for everyone. And then chronic is greater than 8 weeks. The most common ones are upper airway cough syndrome, which is postnasal drip, asthma, and GERD. And so you have a lot of other things that this could be, but because the overwhelming majority, like something like 90%, are represented by those 3 diagnoses, you're going to go by their symptoms and their history, pick, the number 1 diagnosis out of those 3, start treating that. If that doesn't work, move on to the next one. If that doesn't work, move on to the third one. If you've kind of gone through all 3, then you're going to move to more testing. If at any point during that algorithm, they're like, ooh, I got a little benefit, but I'm still not better, continue that treatment. So like say, I think it's, upper airway cough syndrome, I'm going to start an antihistamine or decongestion. decongestant, that helps a little bit, but they're still not doing as well as they want to. Then say, I think GERD's the most likely. After that, I would keep either the antihistamine or the decongestant and then start a PPI on top of it. If it didn't help at all, then I would just stop that and switch to a PPI. And then, if you think that it's asthma, you are going to do some diagnostic testing, so definitely PFTs. And then this kind of interesting non-asthmatic eosinophilic bronchitis is, I guess, fairly common. And in order to diagnose that, you're going to need a sputum eosinophil count. And these are patients which benefit from inhaled steroids. And then kind of these other ones down at the bottom. So chronic bronchitis, ACE inhibitors, malignancy, insidious infections. Once you get to chronic cough, everyone's going to get a chest x-ray, and if they're smoking, you're going to tell them to stop. And then if they're on an ACE inhibitor, you're going to stop that too. So this is everyone, but not everyone's going to get PFTs, not everyone's going to get pH monitoring and all that. Let's start with the most common and then kind of move down the line. Any questions about that? All right, let's go through. We'll do dizziness and vertigo, and then we'll take a break. So for vertigo, you have two types. You have central peripheral, and then other types of dizziness are presyncope, disequilibrium, and then non-specific lightheadedness. Vertigo is highly testable, so this is something that I would try and commit to memory. And so vertigo, that sensation of spinning, is worsened by head movement, no matter whether it's peripheral or central. In the clinic, you're going to use the Dix-Hallpike maneuver in order to aid in your diagnosis. And what you're trying to figure out in the clinic is this peripheral or is this central? And so there's a couple different things that can help you with that. And so for nystagmus, peripheral vertigos can give you unilateral. It has some latency, so after you do the Dix-Hallpike maneuver, there's going to be a pause, and then they'll start having nystagmus. And then the nystagmus is going to last less than a minute. And this is in contrast to central. So their nystagmus can change direction. So if they look one way, it's going to go one way. If they look another way, it could move direction. And then there's no latency. It basically starts immediately, and it'll last for longer than a minute. The symptoms in peripheral are going to be more severe than in central, and if you continue doing testing, the symptoms will actually get less. In the peripheral vertigo, peripheral vertigo is also unlikely to have other neurologic signs. Central vertigo often does, but doesn't have to. So that's the kind of scary one where, you are trying to figure out if they have central vertigo, and you're like, well, they don't have other neurological symptoms, but that doesn't have to be the case. And then in peripheral vertigo, they can usually walk, but they may kind of walk to one side. And then those with central vertigo are unlikely to be able to walk. And then people with peripheral vertigo may have hearing complaints. So when going through the differential diagnosis of vertigo for peripheral, the one that we think about, the main one is BPPV. And then you also have vestibular neuronitis, Meniere's, acoustic neuromas, and then kind of some less common ones. Kind of the main thing that you want to remember is Epley exercises for those people who you think have BPPV. And these are exercises that the patients can do at home. You just have to give them a handout that shows them how to do these. For central vertigo, the reason why you're trying to figure out if someone has central vertigo is that, the cause of this is likely to be ischemia. And there's a couple other exam maneuvers that you can do in order to figure out if they have central vertigo. So does anyone know what skew deviation is? So if the patient's looking directly at you, if they have one eye that has like a vertical misalignment, so or they're tilting their head to try and align both eyes kind of the same level, that would be skewed deviation. And so that favors a central etiology. And then we already talked about the nystagmus. So if nystagmus changes direction, it's more likely to be central. And then does anyone know the head impulse test? So in this test, you're going to face the patient and you want them to focus on something that's about, I don't know, I think it's something like 10 meters in front of them. And then you want to rapidly move their head to one side or the other. So you're rotating it. And you want them to fix on that spot. And so if they have trouble fixating on that spot, then they're likely to have a peripheral. So like you're moving their head and that's going to cause vertigo, right? And they're not going to be able to stay fixed on that spot. So that would be peripheral. So if you move their head really quickly and they're able to stay fixed on that one spot, then you're going to think central. All right, so for those of you that are in clinic in the last couple of months, I think it was last month maybe, you probably know this. For those of you that weren't in clinic, we're going to go through hearing loss. So let's go through the different tests. So someone comes in with complaining of hearing loss. Usually it's going to be acute if they bring it up to you. And you're going to do which test first, Weber or Rene? Yeah, Weber. So Weber, you can do it a couple different places. Most people are going to do it at the top of the head. And so he says that he can hear it more on the right. So what does that mean? Yeah, so he can hear it more on the right. So it lateralizes to the right. What'd you say? So the opposite. So it's conductive hearing loss. Yeah. Conductive hearing loss on the side that it lateralizes to, or sensory neural hearing loss on the opposite side. And so then you're going to do the Rene test. And so how do you do the Rene test? Where do you start? On the bone or in front of the ear? Bone. All right, good. And so how are you going to counsel the patient? So what are you going to do? You're going to prompt them, right? You're going to tell them to do something, right? So you're going to tell them, I'm going to place this here. Tell me when the sound goes away. And so when it goes away, you're going to immediately move it to in front of the ear. And you want to kind of be quick about it. And so normal people, their air conduction is going to be better than their bone conduction. So the sound's going to go away when it's on the bone, and then when you put it in front of the ear, they're going to be able to hear it. So that's normal. And so this is kind of where it gets tricky. So if you put it on the bone, right, and then you move it in front of the ear, and they're like, no, wait, I actually heard it louder on the bone, then what is that? Yeah, conductive hearing loss. So if they hear it louder through air conduction, so in front of the ear, then that could be sensory neural hearing loss. But I did say that that's normal, right? So it's normal to have better air conduction than bone conduction. So what you want to do is compare both sides. And so if we thought because it lateralizes to the right, he could have either conductive on the right, we tested that, he doesn't have conductive, or he could have sensory neural on the left. And so when you do the Rene test on the left, the sound with air conduction is going to go away faster than on the right for him. And so that would tell you that he could have sensory neural hearing loss on that side. And so the next thing you're going to do after you do this test, or maybe even before this test, in the exam room, you can look in the ear. That's kind of like another one. Yeah, so you can do whisper test, or you can do the one by rubbing your fingers. But definitely look in the ear in all the patients with hearing loss. All right, so we're going to talk mainly about sudden sensory neural hearing loss, and our clinic topic kind of focused mostly on that. So this is less than 72 hours, and you want to suspect this based on history. So the patient's telling you, I stopped hearing, and then your physical exam. So you do the Weber and Rene test, and you're like, all right, this seems like sensory neural hearing loss as opposed to conductive hearing loss. And so these patients are going to get audiometry. That's how you're going to confirm that diagnosis. And then you're going to discuss this with ENT. So this is an otologic emergency. You're going to call them, and they're going to tell you to do two things at the same time. So let's order an MRI. They want to see that when they see the patient in clinic. They also want audiometry if you haven't already ordered it. And then they're likely going to tell you to start prednisone. So this is higher dose prednisone, 60 milligrams for 1 to 2 weeks, and then taper. So obviously if you're doing 2 weeks, you're going to have to taper. The main thing to kind of keep in mind, so when you're ordering the MRI, you want to make sure that it's with contrast, and then that they do small slices through the posterior fossa and the internal auditory canal. So the internal auditory canal is pretty self-explanatory, but why the posterior fossa? Yep, so that would be a place where you have an acoustic neuroma. Why, right? It's growing on or coming from, yeah, so that's where kind of like the nerve, that's where that comes out. And so that's where you're likely to get acoustic neuromas. And so you want to look kind of right in that area. All right, so the differential diagnosis, so 70% or so are going to be idiopathic, and then you also have infectious causes, and then otologic, so that would be kind of primary ear problems, and then vascular etiologies, and then neoplastic. So your testing is kind of based on, what you think is the most likely. So if they live in an area that's endemic to Lyme, so we don't fall into that, then you would test for Lyme. Pretty much everyone's going to get tested for syphilis if they have this kind of like weird vaccination history, or that you can try testing for bumps. Then you want to, look for people that have other risk factors. So, or maybe other symptoms, and those are the people that you're going to image, either, if you're looking for a CVA, or if you think they're having TIAs. And then this is kind of interesting. So patients with sickle cell disease could end up with hearing loss due to a vascular cause. And then people with these sudden sensory neural hearing loss, they all get MRIs. And the main thing, you're looking for the acoustic neuroma. So tinnitus, it's kind of the other hearing complaint. This is also in the same clinic topic. So it's a perception of sound that's not coming from an external stimulus. And so there's two ways to kind of categorize it or classify it. So you have subjective and objective. So subjective means you can't find a cause or something that's causing that sound. And then objective would be it's coming from somewhere else in the body. So vascular, could be, pulsatile, and that could be either due to some like stenosis or an aneurysm or something. Muscular, these are going to be kind of like head and neck muscles, can cause some muscular tinnitus, or after you go to a really loud concert, you get this kind of clicking sound. And then spontaneous, these are kind of like, it's kind of hard to describe, but if you're walking and you feel like you just all of a sudden started hearing this really weird like AM frequency that you can't explain, it doesn't last for very long, and it happens at random times. We don't know why this occurs, but that would be spontaneous tinnitus. So the differential diagnosis is very similar to sensory neural hearing loss. You're also going to ask about environmental causes. So these are people like usually related to their job. And then you want to think more about medications. So big ones are like salicylates and NSAIDs, diuretics, aminoglycosides. The aminoglycosides kind of fall in the other category too, sensory neural hearing loss. And then you want to make sure that they don't have red flags, because someone with a red flag is going to need an urgent ENT referral. So pulsatile, so that's objective tinnitus. And then if they have persistent otalgia or otorrhea, and then associated dizziness or vertigo, or if they say it's unilateral. And then for the patients that you identify like an offending medication, you obviously want to stop that. And then these people can be greatly affected by this in their life, so screening for depression and using some form of counseling can be helpful in certain people. All right, we're going to go through a couple common musculoskeletal complaints, and we'll start with a question. So, 47-year-old man presents to clinic with right shoulder pain. He's working in construction and injured his right shoulder 1 month ago. He describes pain and decreased range of motion, and then on exam, he does not have any visual abnormalities or any point tenderness. He does have pain with passive and active range of motion. And what is the most likely diagnosis in this case? All right, rotator cuff tendinopathy, olecranon bursitis, adhesive capsulitis, and osteoarthritis. So this is a tricky one. You know, it's hard to really tease a lot of these out based on kind of like history and physical exam. There are some kind of buzzwords in here. What I was going for is adhesive capsulitis, but people that, you know, work a lot with their arms, like either painters or construction workers, you know, can definitely get rotator cuff tendinopathy and olecranon bursitis. So the kind of buzzwords for this guy I was kind of talking about. So he had a previous injury to that arm, and then he's got pain with kind of like passive and active movement, and then definitely complaining of decreased range of motion. And so that was kind of what I was getting at with this. But these can be quite tricky. So for shoulder pain, you have rotator cuff disorders. So this is usually a dull pain, worsened with overhead activities. They may complain of decreased range of motion and weakness. And so the way that you're going to try and elicit a diagnosis is through kind of your exam. So in the impingement test, that's kind of the other name for that might be the kind of like the painful arc. They definitely usually have point tenderness, and then weakness on a lift-off test. So that's when they, put their hand behind their back. You ask them to kind of push away from their back, and then you're going to resist that. And so they should have, weakness with that. And so that's usually going to be with full tears. The kind of couple things to keep in mind is you want to make sure this isn't referred pain, because the treatment and workup is completely different if it's referred pain. And then if someone has a full tear and you think they would be a surgical candidate, that's when you would get imaging. And usually most people aren't getting surgery for anything other than a full tear. And a lot of orthopedic surgeons say that they only do surgeries on young athletes that have full tears, but it differs from surgeon to surgeon. This right here is just a picture, if we get it, of the weighted or unweighted pendulum exercises, and so this is something that you can tell patients to do at home. Certainly if they have a rotator cuff, maybe not necessarily full tear, but anything other than that. Other major one is adhesive capsulitis. So these are likely to be older patients. They may have had a prior shoulder injury. I did read that people with diabetes are also more likely to develop adhesive capsulitis. They're going to complain of pain and loss of shoulder movement. They typically don't have any visual abnormalities. They don't have any point tenderness, but they have quite a bit of pain with passive range of motion. It's usually decreased too. They won't let you examine them. So the interesting thing with adhesive capsulitis is that there's a push towards doing early steroid injections followed by physical therapy, and there seems to be more of a benefit for steroid injections with this as opposed to like a rotator cuff pathology. In that case, the rotator cuff pathology really is just going to be physical therapy. Carpal tunnel syndrome, this is another complaint, so like hand complaints. This is a common thing that we see in the clinic. The main things that I want you to kind of keep in mind, so we all do like thorough exams in the office. The specific, physical exam maneuvers that we do don't have a lot of diagnostic utility. But it is important, I think, to look for muscle atrophy. And so if you have muscle atrophy, that means you have severe disease. And these are people that you're going to be more likely to refer for surgery. And you don't need routine nerve conduction studies. Most of these people, if you think this is what it is, and it's not severe, you're gonna, put them in a splint. Splinting for the whole day is better than at night, and see how they do. And then you want to look for things that can exacerbate this kind of median nerve entrapment. So diabetes, thyroid disease, pregnancy, these are kind of things that I'll look for. The other thing is obesity, and so I'll say to someone that has this, we'll get you a splint. We need to work on losing weight. We're going to look for other things like diabetes if they don't already have that or know that and they have that, and then also look for thyroid disease. And I usually ask them if there's any way that they could be pregnant. Low back pain is our favorite. We'll probably fly through this since we see a lot of this. So the main thing is the difference is acute versus subacute and chronic. So acute is going to be less than 4 weeks. The majority of these people have non-specific low back pain, and they'll get better on their own with literally any intervention that you choose, and it's pretty quick. The main thing that you want to just make sure in these patients is they don't have something else other than non-specific low back pain. So you want to look for red flags, and if you have those, then that's when you get imaging. Otherwise, you don't routinely image these people. And then subacute and chronic low back pain. So usually you're going to start with physical therapy and acetaminophen or an NSAID. And then if they don't respond to treatment after 6 weeks, then you can do imaging at that time. And then kind of like your adjunct therapy, so it could be like acupuncture or yoga or CBT. You're not necessarily going to use for subacute, but definitely in chronic low back pain. Hip pain. So I actually really like this topic. I think this is something that's easy to grasp, and I put these 3 diagnoses on this slide specifically because I think that you can try and break hip pain up into different areas. So for osteoarthritis, it's usually going to be anterior and radiating to the groin. And then it's worse with weight bearing. And then when you're doing physical exam maneuvers, if you have them laying down, if you do internal and external rotation, like usually they have pain with that. Trochanteric bursitis, so more lateral pain, so it's a different kind of anatomic area. And then they're going to tell you that they have pain when they're lying on that side. And then definitely going to have pain with palpation there. And then the last one, piriformis syndrome. So this is going to be more kind of like posterior buttock pain. And prolonged sitting, so like truck drivers, that's a risk factor for that. And kind of the main treatment for that is going to be stretching. And so you have to give them specific stretching exercises, and then they should get better after that, but they have to be pretty vigilant about doing stretching. Other causes that you might see, so neuralgia paresthetica, so that's entrapment of the lateral femoral cutaneous nerve. So these are people that are, obese or have diabetes or have tight clothing or belts, and they have anterior thigh pain and paresthesia. The other one is avascular necrosis, and so they're going to start out by having pain with movement, and then it's going to progress to having pain at rest. We have a couple patients in our clinic that have extremely severe pain, constant pain, requiring narcotics. Risk factors for this, so we always think about steroids. The other things that we don't always think about, so prior radiation, and then sickle cell anemia. And then you need to do imaging, so this could either be plain films, so late in the disease, plain films can diagnose this. Early on, it would be MRI. And then these patients should be referred to orthopedic surgery and hopefully get a hip replacement. All right, so you have a 31-year-old man who presents to the clinic with right knee pain. He had an injury while playing soccer the previous evening. He heard a pop, felt severe pain, and was unable to continue playing. His knee is now swollen and feels unstable. On exam, he has right knee effusion without erythema or warmth, no joint line tenderness. He has a negative posterior drawer test, a positive anterior drawer and Lockman test. So what is the injury for him? Who thinks meniscal tear, ACL tear, a lot of hands, a PCL tear, and MCL tear? All right, good. So this is a ACL tear, so rapid decellularization with pivot. You kind of hear this popping sound. You have severe pain, swelling, and joint instability. These people cannot continue playing if it was during a activity or athletic event. And then you have the positive anterior drawer sign and Lockman, PCL. The stem might have a car accident patient, so you have the knee is flexed and then you get force that's directed posteriorly. That might be what you see on the stem for patients with PCL tear, and they have the positive drawer test. So anterior drawer, it's flexed at 90 degrees. You put both hands with your thumbs kind of right below the tibial plateau, and then you pull out. The Lockman, you're going to have one hand on the anterior portion of the thigh above the knee, and then the other hand is kind of like behind their lower leg, and then you kind of push down with one hand and pull with the other hand. So you're going to push down on their femur and pull out on their tibia. And then, so the MCL and LCL, these are going to be pretty straightforward. I mean, they're going to have point tenderness, and then when you stress it, it's going to be on the side opposite to what side you're pushing with your hand. All right, and then for meniscal tear, so this is, if you have your foot planted and then you have a rotational injury while the knee is flexed, they'll have some, pain with rotational movement and then a sensation of catching or instability. And then, you'll treat with physical therapy, and then if they have severe mechanical complaints or limitations, then they'll get surgery. These people, after they have this injury, can sometimes keep playing, and so this is different than in an ACL tear. So knee pain, we're going to skip osteoarthritis and go to some other kind of less common ones. So for bursitis, there's two types. There's prepatellar and pes anserin. So prepatellar, I think that the things to kind of think about, so these are people that work on their knees, and actually you need to do a diagnostic and therapeutic aspiration in these people. So that was something that I didn't necessarily know. We don't see a lot of this, and so that's not something that we kind of keep in the back of our mind. But that is in contrast to pes anserin bursitis, and so this is in a different area. So this is medial. It's going to be anterior medial and just kind of like below the knee joint. And then, so it's common in runners, and they're going to have point tenderness. There's almost always a question with pes anserin bursitis on ITE or boards. I think it was on my boards. So, other syndromes, so patellofemoral pain syndrome. So that's going to be this kind of non-specific anterior knee pain. Interestingly, you can get it from prolonged sitting, or runners get it. And if you have someone where on the stem they say that the knee is fully extended and then you press down on the patella and you elicit the same pain, and this would be patellofemoral pain syndrome. IT band syndrome, also common in runners, but this is going to be lateral just above the knee joint, and that's where you have point tenderness, and you're going to treat it with NSAIDs and rests. All right, we're not going to spend a lot of time on the last couple of topics. So dyslipidemia, I think the important things to point out is, so the United States Preventive Service Task Force recommends screening at age 40 to 75, but the ACC/AHA recommends starting screening at 20. There's a movement towards catching all patients, so it doesn't have to be fasting. And so for those of us that had a clinic in the afternoon, that was one thing that we had trouble with, and then so we just started moving to afternoon testing, non-fasting testing. That actually ended up being in the guidelines. And then really what they say is that they're trying to identify people with high ASCVD risk, but really what we're trying to do is find people that we're going to put on statins. And so therapeutic lifestyle changes that might be an answer on a test. So these are patients, anyone whom you're going to start a statin, you're also going to have them do lifestyle changes. But people that you think have risk factors that don't qualify for a statin at this time, definitely do lifestyle changes. That will be the answer. These are the kind of four main groups. So if you have clinical, like if you have known coronary artery disease, or you've had an MI, so these are people who are going to be on high-dose statin. And then if you're over the age of 20 and you're screening and the LDL comes back and it's greater than 190, then you're going to be on a high-dose statin. And then people with diabetes, so this is a different age range, so 40 to 75, diabetes, and then the kind of LDL that falls in that range are going to be on a moderate to high-dose statin, and that's going to be based on their ASCVD risk using the calculation. And then everyone else, so if they don't fall into any of those other categories, you're going to calculate their 10-year ASCVD risk and then, do a statin, either, moderate or high or even low if you think that they can't tolerate it based on their risk. So key things to point out. So check LFTs before you start. You don't have to check your CK. You don't do any routine monitoring of LFTs or CK. If they have symptoms of like liver toxicity, you're then going to check their LFTs, and then you can discontinue if it's greater than 3 times the upper limit of normal. And then if they have symptoms of myopathy, that's when you're going to check your CK. I think it's interesting to point out that there are different cutoffs for different groups of people, like I think men versus women and maybe African American versus other races that have different levels that are considered normal. And then, if you have someone with liver toxicity, myopathy, or intolerance, then you basically want to attempt to treat these with the lowest dose possible or switch to a different statin. High-risk people, there's not, and some groups have recommendations for continuing to check lipid panels, but not all of them. But basically, I think what most people do is if you have a high-risk person that's on a high-dose statin, you're going to check their LDL and you're looking for a 50% reduction, and that's basically the test for compliance. And then if you have a high-risk person that's not responding the way that you would like them to on a high-dose statin, you can add ezetimibe, but there's no guidelines for starting two kind of at the same time right in the beginning. So obesity, I think the key things to point out, so your cutoffs for overweight and obese people, there are different cutoffs for Asians. So for the overweight group would be 23 to 27, and then for obese it would be greater than 27 in Asians. And it's important to kind of measure waist circumference in people. So if you have someone that's overweight but they have a lot of abdominal fat and you check a waist circumference, that also correlates with increased ASCVD risk as that goes up. So it's important to check that too. There's a lot of associated conditions with this, so your workup is going to be kind of tailored towards looking for those other things that they don't have any of these other things diagnosed yet. So screen them for OSA, screen them for depression, You're checking blood pressure, CMP, A1C, lipid panel, and TSH. The treatment is going to start out with an exercise plan, so you want a goal weight loss of 10% at 1 pound per week. And then you can use medications in specific populations. So if their BMI is more than 27 with a comorbidity or greater than 30, so this is different from surgery, so where the indication would be a BMI greater than, that should say 35 actually, with comorbidities, or a BMI greater than 40. That would be indications for surgery. So, other reasons to use medications would be if you don't get if you don't get more than a 5% weight loss, or you want to sustain weight loss. Medications are expensive. They don't have the best efficacy. They can have a lot of side effects or contraindications. And then when you stop them, they don't have a lasting effect. So we'll go through a couple of different ones in here. And this, I know this is a really busy slide. I'll just kind of highlight some things on here. So orlistat, so that's going to block fat absorption, so they're going to have a lot of GI side effects. You're going to definitely have trouble absorbing fat soluble vitamins, and then you're going to have trouble absorbing like other medications, so specifically Synthroid. For lorcaserin, I think the main thing to kind of look at for these people is, so you want to avoid these in people with severe liver or kidney diseases, or people with heart block or CHF. And then the big thing to watch out for is syndromes related to serotonin, so serotonin syndrome or NMS. The phentermine topiramate actually has pretty good efficacy. So at the highest dose, 9% weight loss at 1 year. A lot of people don't like taking it because they kind of get this fog, these kind of like cognitive changes, and it has a lot of kind of like safety concerns. So definitely tachycardia, and then contraindications in a lot of different things. So recent MAOIs, hyperthyroidism, pregnancy. Most of these are actually contraindicated in pregnancy or breastfeeding. And then acute angle closure glaucoma. Next one, naltrexone, bupropion. So this is the cheapest, but you can't give it to people that have epilepsy or opioid therapy. And then, I didn't know this, but uncontrolled hypertension, it can make it a whole lot worse. So you shouldn't give it in those people. And then people that have controlled hypertension, you want to make sure you're monitoring this in people that are on this. Last one is the most expensive. It's the newer agent of these, and it's for people that have diabetes and obesity. So it's a GLP-1 analog, and then it has pretty good weight loss at 1 year. The big things you want to watch out for: MEN2 and personal or family history of medullary thyroid cancer. So I think this is the last slide. So depression, so you want to screen all adults. You can use PHQ-2 or 9. You definitely want to screen for mania in these people, because the first line treatment is going to be an SSRI, and then you also should refer them for psychotherapy. That could either be with a psychologist or a psychiatrist. And then you want to counsel them on this medication, and then titrate to the highest dose. If they don't have improvement at the highest dose you can get to, then switch to another SSRI. So you don't have to taper it back down and then start another one and taper that back up. You can switch without having to worry about this kind of withdrawal syndrome. And so that's something you definitely want to tell your patients. Like if they start having a lot of side effects, like if they abruptly stop it, they can end up with withdrawal syndrome. It can be very unpleasant. And so the reason to refer to psychiatry would be SI or HI if they have psychotic features, if they have evidence of bipolar disease, or if you've tried 2 SSRIs or an SSRI and then an SNRI. You've tried a couple different things and they're still not getting better. That's usually when I refer to psychiatry. But we're having trouble getting people into the clinic, so we may be trying more than just 2 medications. So I believe that's the last slide.